Hi everyone, how are you? My name is Dr. Ghaderi. I'm a plastic surgeon, reconstructive surgeon with experience in breast reconstruction after mastectomy. Doing a Facebook Live today with Living Well, part of Northwestern Medicine. And they have a lot of great programs here that I'm sure many of you watching may have already enjoyed, as far as different groups and different support environment that people go through cancer, many types, and obviously my patients, specifically breast cancer, have benefited from this building specifically for many, many years. Please send your questions in. I know we already have a few, so thank you. But I'm going to start with some general discussion about breast cancer reconstruction after mastectomy. And if you have anything that you want to ask about, please feel free, and we'll be able to answer them. So breast reconstruction starts with really the mastectomy. Over the years, the last even few decades, breast surgeons have really improved the way they do mastectomies, and that's helped us get a much better reconstruction and much more natural appearance. So definitely have to say thank you to the breast surgeons who take care of everybody from lumpectomies to mastectomies. You may have read, or many of you may have lived through mastectomies where the nipple was always removed. Now, of course, nipple sparing is something that's very common and attempted at any point for most patients. And the next, I think, frontier is getting sensation to the breast and maintaining it. I know there's some people that are in the country are doing that. So far, it's still very experimental, but I think that's the next step, is to maintain sensation, as that is a common thing that patients are obviously feel through, even though they look good in front of the mirror, but they don't feel it, and that's a very important part of making somebody whole again after such a drastic event. So with reconstruction, it's a step-by-step process. Everybody's going to have a different story. Everybody's going to have a different way that they decide what they want to do. In the end, it's what makes you feel the best. It could be doing nothing. It could be the so-called going flat, where you just have a mastectomy and maybe not even wear a prosthesis. You're comfortable enough that you've treated the cancer, and that's your main goal, which is everybody's. And the appearance is something that you can adjust to. And the next step would be to do actual reconstruction, where you can have a breast shape, breast mound, and look like your previous self. And it could be something that could be done at the time of the mastectomy. That's called immediate reconstruction, and that's what most people want. The process for reconstruction is meant as an emotional health benefit. When you go to sleep and wake up, that's a drastic change to your body and your body image when you wake up and obviously have no breasts. It's a feminine part that makes you feel whole, balanced with your shoulders and hips. Wearing something as simple as clothes and going out on a night to a dinner, be able to get dressed. So, and waking up without that can be emotionally taxing, and emotional health can definitely affect your immune system and how you recover. So the reason we do reconstruction, and the reason we want to do immediate reconstruction, is so that that effect is lessened. So when you wake up, you look down and you can actually see, okay, I can handle this. I can get through this. So immediate reconstruction is definitely preferred, but delayed is for some people beneficial as well. Maybe the cancer is too spread and they need the testing and the chemo and the radiation right away. Maybe the whole process could be overwhelming and they want to take time to think about it. And then the next step would be whether you want to use your own body tissue or whether you want to use implants. Most people, about a good 85–90% of people, use implants. They're easier, less risk, and obviously speedier recovery. Body tissue has its own benefits. It's your own body. Be able to have your own tissue transplanted into the breast and be able to reconstruct that breast where it's permanently done now. Whereas obviously implants have a life to them, generally about 10 to 15 years. But again, implant surgery, the reason most people choose that, is a less involved surgery, less recovery, and a lot of times now it would be outpatient, whereas body tissue would be an inpatient type surgery. If there's any questions, again, please let me know and we can address that. And as far as the decision tree goes, once you've decided body tissue or implants, And again, body tissue would be, for example, from your tummy, from the back usually. Radiation in the past would involve some decision making, which body area that is used best. But the tummy is the most common one used. And obviously everybody jokes that we get a tummy tuck out of it. But yes, it's a very involved surgery. But yes, the tummy tissue is used to reconstruct the breast, one or both sides. And that's another thing that people consider is once they are facing mastectomy, would it be something that they want to do both sides or one side? The two concerns about that is, one is cancer. So once you've had cancer, on, let's say on the left side, are you worried that you might have it on the right? And next year when you go get a mammogram, is that going to wear on you for a week or two to get your results? And what if they call you back and say, we need more testing? So some people just don't want to deal with that, and they opt to have bilateral mastectomy or both sides. The other one would be just simply symmetry. Once both sides are treated, you're more symmetrical. One side, let's say, hangs more naturally. If you have a mastectomy on the opposite side, tends to lift and be uneven. So the two concerns that people decide whether they have one side or both sides treated would be, one, just lowering the risk of cancer on the other side, or even just a testing, not to have the concern next year or the year after to have a mastectomy or a lump come up that they feel, and all those feelings that they had the first time diagnosis came around, to go through it again. And then the other one would be, again, the symmetry. As far as implants go, there are two methods. One would be the direct-to-implant, if that term has been something you've seen, where once the breast surgeon has done the mastectomy, the implant is placed and you're done at that point. The upside with that is obviously one surgery done, you wake up and you're complete. The downside would that be there's some loss of control over the size. Some people may want to be a little bit fuller. Some people want to maintain their size. Once you do a mastectomy, the blood supply to the skin is compromised, may not tolerate the same size as you were before surgery. So direct to implant may limit some of that sizing options. That's why tissue expanders, which many of you, if you've unfortunately been going through breast cancer, have heard about, that allows expansion or stretching of the skin after you're healed and does allow you control over your size, but then it does create a second surgery down the road to have to go back and take out the expander and put in a silicone implant. And the last part of it would be whether you go above or below the muscle. That's been the last few years a resurgence of going above the muscle. A lot of people who've had maybe reconstruction 5 to 10 or 15 years ago have had their implants placed below the muscle, and now the trend is to do above the muscle, and that's had good results as far as the outcome goes. There's benefits and risks with both, and we can go through that as questions come up. But for now, I think that's the main decision process would be immediate or delayed body tissue or implants. And if you do choose implants, is it one step or two steps where you have direct to implant or expander and implant? And the last question would be to ask yourself would be, do I want it above or below the muscle? And that's something you can discuss with your surgeon based on your specific situation. So I hope that's an overview, and we can definitely start going through some questions, and the more the better.
So speaking of above and below or under the muscle, Charlene is asking if an implant is put under the muscle and converted during a second surgery to over the muscle, since the muscle is already stretched out, what happens to the muscle?
So if you're switching from under the muscle to above the muscle, that muscle would have to be, the capsule that's formed around under the muscle would have to be removed at that second surgery, and the muscle can be tacked down back to its native position. The muscle does retract and may not be back to normal like it was before the first surgery, but it can be put back in its normal anatomical position, secured in place with basically sutures, and the implant can go above. That is a bit of surgery to do, and would have to be, obviously, if there's a discomfort to having under the muscle. One thing that people complain about is animation deformity, where when the muscle flexes, the implant moves, and that causes some discomfort, and that's why above the muscle would work in that situation because that would eliminate any muscle movement of the implant. It's definitely doable, and the muscle can be tacked back down to the chest wall in its more anatomical, normal position.
There's a question that came in through Facebook. Shar is asking, her implant has been recalled. Have you treated anyone with a recalled implant?
Yes, there implants about a year and a half ago or so. There was one company that had their implants recalled, the textured specifically implants that had a higher risk of lymphoma related to implants. And as of now, that risk is very, very small, but rightfully so. Many people are worried that they don't even want to have the risk, and especially when you got treated because of a cancer, to have somebody tell you that you're at risk for another, that can be disheartening. So yes, over the last year and a half, we've treated many people that have had that textured implant, and the treatment involves removing the capsule in its entirety, as well as the implant. And then again, option would be if somebody does not want to replace, which is rare, but that's possible. But most people, what happens is we replace the implant with a smooth surfaced implant, which as of now has not been shown to be connected to that lymphoma. So yes, that's a, hate to use the word easy because it is surgery, but it's a common procedure done to alleviate any risk of that lymphoma, plus obviously the benefit of just mental health of knowing that that risk is gone.
Leanne asked, how common is capsular contracture and what are the options for dealing with it? Does physical therapy provide some relief?
So capsular contracture is something that happens when you have a foreign body like an implant placed. When people do this for augmentation, they still have a risk, but the risk is much lower. It's less than 3%. And under the muscle is been shown over the last couple of decades that that rate goes down. Now, with above the muscle being wrapped in dermis, human dermis, that's also been shown to minimize the capsular contracture. But just to give you a perspective, even people who do augmentation, which is just implants to have a fuller size, they still have a risk of that. It's about 3%. Once you get to do a mastectomy where lymph nodes are removed, and obviously more surgery, more inflammation, that risk goes about 10 to 15%. But really that's still, if you look at it in a positive way, 85, 90% of people don't have capsular contracture. There's only one thing that does really make that risk go up, and that's radiation. Once the radiation has happened either before or after you've had reconstruction, that radiated skin is very tight and fibrosed, and the capsule around the implant can tighten. So radiation doesn't affect your implant itself. Capsular contracture is not an implant that tightens, it's the tissue around it. And so once you've had that radiation basically treats that skin, and that capsule is very thin right there because the breast is gone, so that radiation can hit the skin and the capsule. Once that tightens, that hardens around the implant, and that risk is about a good, I would say, 90+% once you've had radiation, that you get that hardening. So it's an expected process. So radiation is really the only one that increases that risk a lot.
A patient wrote in and said she had a lumpectomy with radiation about 16 years ago, with followed by a bilateral mastectomy with saline implants. She's asking, knowing that the radiation has some side effects for reconstruction, how at risk at this point that the implant replacement would be problematic on the previously radiated side?
So as far as having radiation in the past and having a lumpectomy and then having obviously a mastectomy radiation and having the implants now be 10 to 15 years and wanting them replaced, implants don't necessarily degrade. They can break. On average, it's about 10 to 15 years, but they can last 26 years. I've seen them last even longer. So with saline implants, the nice part is that if they break, you know it because one side deflates. As far as the radiation causing increased risks with the replacement surgery, like any other thing, it would have to be once you do an exam to see if you have mild radiation changes, if you have moderate or severe. So if you have mild radiation changes, I've done many surgeries on people who've had radiation before and people have healed well. But yes, radiation does increase your risk of not healing because that tissue is very much fibrosed and thinned out, especially with an implant over the years. So it would be an evaluation that's done. The surgery is possible. It can be successful, but yes, the risks are higher. And as far as saline implants go, because you've had radiation, I would suggest just waiting, because there's no harm if the implant breaks. If the implant breaks, it's saline, which is good and not bad in your body resorbs it. You'll know it. There's no testing to be done because it'll deflate. So if you can maybe get another 5 or 10 years from that implant, which is possible, I would say unless you have some discomfort from the potential capsular contracture related to the radiation, or just want the implants changed before they break, I would say because of that radiation increasing that risk, I would wait. But definitely you can go see your surgeon if you still see them, or go get a consult from a new surgeon if they're not around anymore, to be able to evaluate your skin and see what type of surgery would be the least risk. But for now, saline implant, I would say wait.
Do implant exchanges have to be done under general anesthesia?
So anesthesia is something that's changed over the last, I would say, even 20 years. I think people my age and above probably are more afraid of anesthesia because of the stories maybe 20, 30 years ago. But anesthesia is so safe these days. Safer than driving, safer than flying. If you're otherwise healthy, which again would be something that you would talk about during your consultation, then anesthesia is safe. The risks are extremely low. Sometimes people even prefer it because then you don't remember the process of having surgery. But implant exchange, if it's simple, if you're not doing anything to the capsule, it can be done under local anesthesia where you just make an incision underneath the breast, take out the implant and put a new one. But in general, there's a little bit more involvement of that, whether you have to treat the capsule. Some people these days want fat transfer to their breast, and that would be obviously treating 2 sites where you have to get the fat and put the fat in the breast. So general anesthesia is generally used, doesn't have to be. It's a very individual per patient type decision. But overall, I would reassure you that general anesthesia is extremely safe these days. You might have a better experience not being awake during the surgery.
Angela asked, I have breast implants and sometimes I get an itch that is from the inside of my breast and I can't scratch it. What causes that?
That is a common thing that sometimes people say. It could be nerve injury. As long as the frequency of it is not to the point where it's limiting your daily activities. I have had a hernia repair about 6 years ago, and the incision is very small on my tummy, and every so often, if I'm doing too much or working too much, it starts to hurt. Or sometimes that feeling of itching happens and it goes away. The cause is likely related to something with nerves. There's nothing bad happening unless, again, there's a fever or redness or something. So I would say that I wouldn't worry about it unless it becomes something that's limiting your daily activity, or is so often like a daily event where you should go get an MRI or something to see if there's an implant that's broken, but unlikely to be related to anything bad.
What are the reasons for and against doing reconstructive surgery at the same time of my cancer surgery? So immediate reconstruction versus waiting or delayed reconstruction.
So immediate reconstruction, the benefit of it is, like we talked about earlier, would be to have a breast when you wake up, to be able to feel whole as soon as possible, plus only have one surgery where they do the mastectomy and you can have the reconstruction at the same time, one recovery, and be able to go through the process much quicker. The downside with immediate reconstruction would be obviously increased risk. You're having 2 surgeries, a mastectomy and a reconstruction. The risks overall are low, but that would be one downside. Delayed reconstruction, the benefit would be you're separating out the risks. You're doing a mastectomy, letting it all heal, seeing how you feel, seeing what you want, and also the risk of the reconstruction surgery is now just by itself. Done later, whether it's 3 months or 3 years down the road once you're done with treatment. The downside is not having the breast when you wake up, and that emotional change and that body image change.
Does reconstruction interfere with chemo or radiation therapy?
Reconstruction should not affect anything. The only time it would affect anything as far as your treatment goes, if you had a complication such as infection or not healing, and then you'd have to go through another surgery to remove the implant, then at that point, obviously, if you're not healed, your oncologist would not start chemotherapy, and your radiation oncologist would not start radiation. So there's a risk that it might delay treatment, but in general does not affect your treatment in the end.
Julie submitted a question. She's had a single mastectomy 7 years ago. She's having a noticeable imbalance now. Can we fix this, or is it complicated?
Any surgery, I guess, would be considered complicated, but depends on what's happened over the 7 years. If you felt good at the beginning of the process and you felt symmetrical, has something changed, weight, has the other breast gone through anything that maybe some weight loss where the skin has sagged? So it could be as simple as a breast lift on the other side. Have you had capsular contracture on the reconstructed side where it's tightened now and is higher than the other side? So I think overall there's a solution that might be so-called simple, meaning outpatient surgery, maybe only on the opposite side, maybe not even touch the reconstructed side. Or something, let's say the implant is now at a point where you want a different implant, or if you have a textured implant, you want that changed, you can then do that exchange as well as do a lift on the other side or a reduction, depending on why that asymmetry is now here versus when you originally had the surgery.
So I think you might have answered this. Does weight gain or loss and aging impact a reconstructed breast?
So weight gain and aging definitely impact the shape of a breast. As you all know, as you get older, things don't necessarily end up in the same place, especially with skin stretch. And weight gain does the same thing. As you gain weight, the breast gets larger, which means the larger the breast is, the more sag it has. So yes, with weight gain and aging, the breast skin and the weight changes. So if one side has had a mastectomy, there's not much fatty tissue there. So they won't get large. It'll stay the same size as you gain weight. And when you age, the skin doesn't change much. Versus the opposite breast, which if it's a natural breast and you gain weight, it does get larger. And obviously when it gets larger, heavier it is, the more sag it has. So at that point then, with years and time, it might need a lift, whereas maybe originally when you had the surgery, it did not.
Sonia wrote in, is there a general rule of thumb as to when implants need to be switched out? I was told no by my doctor, but often hear this 10-year time frame quoted by many of my friends who had reconstruction. And does it depend on the type of implant?
So changing out the implant, when should you do it? When does the implant so-called need to be exchanged? The 10 years or 15 years comes from the average. So that's been talked about, and I think some people take that to mean you have to do it. So you have two choices. If you ever want to go through the implant breaking, then yes, people do come in every 10 years and change them out. But the downside with that is that you have more surgery than you need, because what if your implant lasts 20 years? You could have avoided a whole surgery. So I would say that's something that's specifically, again, discussed with your surgeon, that if you are, let's say with a saline implant that we talked about from a question earlier, I would not change it until it's broken, because saline in your body just resorbs, you know it, there's no testing to be done, there's no MRI, there's nothing, you would literally just know, and there's no harm. But the type of implant may make that decision a little bit different if it's silicone implant. Silicone is safe, but when it breaks, you don't know. Just imagine a bowl of water, which is a saline implant, versus a bowl of Jello. If a bowl of water gets a crack in it, the water kind of flows out, and you know that okay, there's a crack in the bowl. But a bowl of Jello, you don't know, because until you look at it. And the only way to look at it is through an MRI. So the FDA does recommend getting an MRI often with gel silicone implants to see if they're broken. There's no harm when they're broken, but you should change them, because it can cause increased inflammation, which can cause the capsular contracture to happen. Rarely I've ever seen somebody have an infection from a broken implant. That's rare, but more than that, more likely it's more of a shape change. So I would say as far as timing of the implant change would be, if you have a saline implant, if you're otherwise comfortable with it, just leave it. When it breaks, there's no harm, you know it. So what if you get 20 years out of it? There's no need to do a surgery every 10 years. With silicone implant, if you don't want to do an MRI often, then changing it out at 10 years would obviously you would catch it right before it would, on average, break. So that's where that 10 years comes from. There is no rule, but that's the average.
Susie is asking, can a mastectomy scar that indents be fixed? It's just about 1 to 2 inches section of the scar that indents.
So yes, that can be something that can be improved if you have a scar on the mastectomy incision that indents or has a shape that you don't like. Scar revision can be possible. Depending on that specific reason, that scar can be cut out and re-sewn, or simply with fat transfer, there's some fat that can be put underneath the scar to kind of bump it out so it flattens out. So scar revision on mastectomies can be done. That could be connected and combined with, let's say it's 10 years out, 15 years out, and you have an implant that now may need to be changed, you can do it at the same time. Or if you have rippling that shows through the skin, you want fat transfer, you can do a scar revision. So you can either do it by itself, or if it's time to do something else to modify or revise your reconstruction, you could do it at that time.
Julie wrote in, my lentiginous flap reconstruction has extensive scarring. What do you recommend to fix keloid scars?
So keloid scars are tough ones. Keloid scars that may happen are unfortunately something we still don't have solutions for, but they're commonly misdiagnosed. Keloids are actually scars that actually grow like a cauliflower. So if your scar is more just thick and raised, it's semantic, but it's important. It's called a hypertrophic scar, which is what most people have. That scar can be either injected with steroid, Keloid, to see if it can calm down, but you have to be careful because if that skin is already thin and radiated, then that may not be a good solution. Then the scar revision may be more of a solution surgically, but again, like we talked about earlier with radiation, would that be a beneficial thing? But if you've had a latissimus dorsi flap, which is the skin and muscle from your back, that usually tolerates things better, such as radiation and scar revision. So yes, scar revision would be one option, but if it's a limited area and it's just a hypertrophic scar, and otherwise your reconstruction is intact, then steroid injection with Keloid would be helpful.
With reconstructive surgery, breast cancer surgery, what do most insurance companies cover and not cover?
We actually talked about this before we started the session. So insurance can get confusing. So coverage by law in 1998, President Clinton signed a law that says all insurance companies have to cover reconstruction if they cover the mastectomy. So by law, they have to cover it, but coverage, that term has changed over the last even 5 years, even 20 years. So before, with all of our insurances, coverage meant that we paid very little or nothing. But over the years, I'm sure you've noticed your own insurance with job changes, and especially since big healthcare changes in 2013 happened, that deductibles and copays have gone up. So even though they cover reconstruction, you may still have some out-of-pocket costs. And that out-of-pocket cost will be determined by your benefit plan. Some people may have as low as $500 deductible, 10% copay. Some people, unfortunately, have so-called catastrophic plans, which are $20,000 out-of-pocket, which then would be almost out-of-pocket, just even though it's covered, it's out-of-pocket. But yes, insurance definitely covers anything, including opposite side surgery. So let's say you had a mastectomy and now you on the left side, but your right breast sags, the lift is covered under by that law. Or if you want to have both mastectomies, you only have cancer on one side. Once you have a mastectomy on the other, reconstruction is covered. So by that law, any insurance company has to cover mastectomy, reconstruction after the mastectomy, sorry, and any opposite side surgery for symmetry.
Okay, last question.
Yeah.
How do I find a reconstructive plastic surgeon, and do I need a referral from my oncologist?
You can find many ways. Usually cancer centers, especially around here, which is a great area, there's a referral pattern in place because a lot of cancer centers, to be certified, have to have a system in place where you can learn about reconstruction. So generally, you will have through your nurse navigator a way to get to a reconstructive surgeon through your oncologist. In general, your breast surgeon who you speak with, whether you do a lumpectomy or mastectomy, will be able to refer you to somebody. And of course, in the end, there is word of mouth, there is your neighbors that potentially have had somebody who was treated, your family doctor. Internet is a place to go as well. Put all those together. Usually one or two names kind of come up as the common people that have experience in the area, and then go see them and see who fits your style the best as far as what you're trying to achieve. Thank you, everybody, for joining us. Hopefully this was helpful, and any other questions, please send over, and we can definitely try to answer them afterwards even. Have a good night. Bye-bye.